Okay guys, I am back. Let's see. We are going to dive into wound healing, chapter 17. I'm going to go ahead and apologize. There may be crop dusters flying over here in a little bit. But I'm trying very hard not to wake up this baby while I do this, because then I'll never get it accomplished. Alright, so wound healing. Like I said earlier, these are some of my most favorite things to lecture over. Just because we see a lot of the surgical perspective, but as surgical techs, we really don't get to see like the after result unless you are, number one, on call a lot, or if you are with a specific surgeon a lot of times, because you'll see them come back. Like if they've had complications with wound healing, you'll see them come back. And that's kind of my experience, so I like to share a little bit of my insight with y'all. So if you ever have questions about this kind of stuff, please ask me, because I really do enjoy this. Sometimes I forget some of the things to add into the lectures, like personal experiences and things like that. So if you have questions, always ask me. Let's go ahead and get started with some of your wound classifications. So this is something that I did see on my boards a little bit. To tell you the truth, I was not experienced in this very well. And so when I took my boards. So that's why I say, if you have questions about this and you're really just not understanding it, please ask me, because it is hard unless you have this kind of bring back and you see like what actually happens, how they close it up again and all that. So with that being said, with wound complications and classifications, you really have predominantly 4 classes. I say that because that's always kind of changing, but right now National Boards is still acknowledging that there are 4 main classes. So a good way to remember it is class 1, think working from the easiest, cleanest up to the dirtiest. Okay, so class 1, clean wound. So really it's just you're closing up your incision, you have no infection, everything was good, clean, went the way it was supposed to, okay? You didn't have any spillage of anything. It's just a nice incision that came together good. Cabbage should really be a class 1. You don't want that to fall under like clean, contaminated, or dirty or anything like that, because that's one of those very important cases that you need no infection. You need great aseptic technique with your closure. There will be times where you will see a cabbage brought back due to, sometimes they'll have an incisional abscess. That it just happens sometimes, guys, especially if you do not have a healthy patient. But the class for a cabbage should be a class 1 clean wound, okay? All right, so then you have your class 2, which is considered clean contaminated. So really what happens is you have that uninfected wound, but whenever you get the contaminated part, it's when you're getting into like the GI and the urinary tract and areas that you cannot technically clean no matter what you do, okay? You know how we always say the vagina, the anus, the mouth, the GI tract, everything like that is still considered contaminated, because there's no way to actually prep it to where it's perfectly clean, okay? So that should give you an idea of clean, contaminated. You're still being very clean. The wound is clean, but it's still contaminated because it's in a not perfectly prepped area. So gastric bypass, you're going to be working with the bowel, the GI tract. Even if you don't have anything spilling out, okay? You have no bowel content spilling out, it's still going to be considered contaminated. Lap choles, that's a perfect example. Sometimes you do have a perfect lap chole where nothing is, no bile or anything is oozing out. Okay, you don't rupture the gallbladder. So try to remember the examples, because I know that's something that comes up in your practice test a lot. Which surgery falls under what class? Just remember, if it is considered like a contaminated, unpreppable, or clean area, then it's considered clean contaminated. May get blown away. It's getting really windy here. Okay, class 3 though, that is contaminated. That is getting into open areas, spillage. Things have started to ooze out, okay? So open traumatic wounds are an example of a class 3. A gunshot, you're going to have some sort of spillage somewhere, okay? It may not be bowel, technically, but you're going to be bleeding from something. There's an open vessel. The gunshot itself brings dirty, contaminated things into your site, okay? GI spillage, say that you have a ruptured bowel, that is going to start to fall. When I say a ruptured bowel, let's say you have a gallbladder that is spilling out everywhere into the abdomen. That's not good, okay? That is the contaminated area. If you have a class 4, that falls under dirty. It's dirty, it's gross, it's not going to be able to be cleaned. You're going to have to do washouts and all kinds of stuff with this. They are most likely to become infected, okay? So a class 4 wound is going to be dead skin, dead tissue. If you have an ulcer, let's say that you have a sacral ulcer or a bed sore, is what most people know it as, that has not been taken care of, that's going to fall into that dirty wound. They're going to have to go in and debride it and clean it out because it is vastly infected. So old wounds that have not been cleaned up are class 4 dirty wounds. If you have a ruptured appendix, that is a perfect example of a class 4 dirty wound because you have stool and bowel contents spilling out into your abdomen. So dirty, any kind of perforated bowel that's leaking, that is going to be a class 4. A lot of those are on-call cases. So just know those patients are going to end up with some sort of infection. If it's in the abdomen, it could be peritonitis. They may have to stay for a little while. So just kind of make sure you know what procedures would go with which classification and which clean, contaminated, or dirty. If you have questions on that, please ask me. I can help you. Let's move on to your phases of wound closures. Okay, so I like to talk about this a lot because I feel like, of course, the better your closure is and the better you're able to keep it clean and nice, the happier your patient's going to be. I know we've covered this before, and y'all are probably like, I don't want to talk about this anymore. I don't want to watch this. That's fine. This is to help people that may be, of course, you know, refreshing themselves, or you've kind of brain dumped this along the way. So, number one, primary, your first intention. You're able to close all of those layers. So, it's a perfect basic case. There's no separation. When you close it, you're not going to have a very big scar. So think about just a basic laceration on the face, or, you know, say you have even a total knee, anything that can be closed, and all layers are closed the first time, okay? Primary intention. Those layers are coming together. As they heal up and granulate and do all of their stuff, they're done, okay? A pretty cosmetic look. If you have secondary intention, okay, this is when you, for some reason, are unable to close the wound completely, okay? They may have some sort of infection. You know, the surgeon may be watching some things to make sure it does not get infected. So what they're wanting with that is granulation to happen. They want, and whenever I say granulation, I know I've told y'all about this before, it looks like sugary, bloody scabs, okay? That's what they want. They want that to heal from the inside out. They can't close it because if there's infection and they close it, it's just going to stay infected and create fistulas and all kinds of really bad things. It can make your patient septic. So, have to be aware of that. A lot of times they will use packing for secondary intention. If they have had like excessive trauma and they can't close the tissue together because there's too much of a gap, they will let it heal by secondary intention. So the main thing to remember with secondary intention, healing from the inside out. You're not able to bring it together. So there's most likely going to be a scar. It's not quite as bad as third, but there's going to be a visible scar there. Third intention is also known as tertiary. So the way I like to teach people to remember it is it's a combination of 1 and 2 to get to 3. So the reason I say you're combining those is because you really are. It's considered a delayed closure. So with that, that means at first you may leave it open to granulate and do its secondary intention to heal up a little bit, to bring some of that tissue together. And then eventually, after they're able to rid the infection, debride it, clean it out as they need to, and it looks healthy again, at that point, they can go in and do their primary closure and suture it back together. So, it's a combination of first and second intention. They want it to heal from the bottom up for a little bit, clean it, debride it, do what they need to, and then they're able to do that primary intention and close it together. I hope that makes sense. Okay, so next, these are just showing you a couple of examples. So, on the left here, you have that really nice, pretty primary intention. They were able to close it. Looks like, well, it's interrupted, but it also kind of looks like a mattress stitch. Really pretty. Once they're done with those sutures, they should just have a little tiny line. Over here, you have that secondary intention because it is a little infected and they can't close that right now. So what they're doing is they're letting it ooze out. They're letting all of that bacteria kind of make its way out. They're going to clean it, do what they need to, and let it heal on its own. Let's see, I think I have. There you go. And then third intention. So, pretty traumatic wound. They were not able to close this because they have a pretty significant loss of tissue. So, they had to clean it, debride it, let it heal a little bit, and then they were eventually able to start to pull what they had back together for their primary closure. So, third intention, tertiary intention, or also called delayed closure. Let's move on. Okay. Now we're going to talk about your phases of healing. So your intentions were how you close your incisions. Now you have how it's actually healing inside there. So when it comes to an injury or any kind of incision or anything like that, you really have three main phases. So you have three intentions of how it's closed, three main phases of healing. Sometimes they like to throw in a fourth, but we're not going to talk about that right now. So whenever it comes to phases of healing, your first phase is your inflammatory. That's that body's reaction to send all of its good, healthy, like fibrin, get everything out there to create that clot. So the inflammatory response sends all of the good tissue there to clot it, to stop it from oozing and bleeding and just having drainage, pretty much. There's not a really good word for it. So this is where you get that scabby appearance, okay? Is your inflammatory phase. Second is what is called your proliferation phase. So the reason I put the different phase names is because a lot of times they want you to know what phase of healing is proliferation. Second, two, okay? So whenever it comes to proliferation, this is where you have fibroblasts coming in, that healthy, good, building up, getting ready to create some new vessels. So that's where you get that angiogenesis. So angio means vessel, right? Okay. Angiogenesis, genesis is renewal or growth of. So angiogenesis is development of those new blood vessels. So it's creating this healthy network to start to heal back. When you have your proliferation phase, that's where you have the greatest increase in the strength of your wound, okay? Because that's where you're getting those new healthy vessels